All right, ready? Okay, so one of the main questions that you're confronted when you're a student or as an internal medicine doctor or even as a nephrologist is whether or not you're dealing with glomerular diseases. We all know that statistically speaking, when somebody has acute kidney injury, the most common cause is ATN, the second most common cause is ATN, the third most common cause is ATN, and then you have all the GNs. But those are the things that you don't want to miss as a student, as a resident, as a practicing specialist. And I always have a problem when a student is presenting a patient to me, and just envision this: you're actually presenting a case to a cardiologist, and you're presenting without an EKG. You don't do that, right? So I have a lot of students coming to present a case to me without an UA, and that's where the money is in nephrology. You look at the UA, and you can pretty much predict a lot of things. I always tell students that your pretest probability or your diagnosis is almost 90% secure in nephrology when you get a good history and when you look at the urine sediment. But there's some instances where the urine sediment can be misleading. We're going to cover some of them. But the purpose of this talk is to help you guys distinguish between different types of glomerular diseases. We're going to cover them like very superficially because each disease requires like a lot of like discussion. But this classification of nephrotic versus nephritic, you guys remember from medical school? You guys, some of the features? What do you guys remember?
Nephrotic, O protein.
Mm-hmm.
Nephritic, no protein.
Right, or less protein. I would say less protein. Yeah, and then I asked that question to one of my attendings, like who came up with this nephrotic versus nephritic? Because sometimes they overlap. And the only definitive way of knowing is by doing a kidney biopsy. So he couldn't really answer. He did some literature research, and he came up with this, it was an England doctor who came up with this classification, and he decided to group these nephrotic diseases in a syndrome. We all know the features. These patients present with a lot of proteinuria, about 3.5 grams. They also present with hyperlipidemia. They also present with risk for infection because they're losing a lot of the immunoglobulins in the urine, and they also present with vitamin D deficiency, and they also tend to have an increased risk for clotting. I don't know if you guys in Europe, actually I don't know if you've seen that in Italy. In Europe, when patients have severe nephrotic syndrome, let's say membranous or other types of nephrotic syndrome, they prophylactically anticoagulate the patients. And the reason being is that they lose protein C and protein S in the urine, which are the natural anticoagulants. So these patients are prothrombotic. We don't necessarily anticoagulate these patients in the United States. We actually put them, we give them a shot. If they have a thrombotic event, yes, we do anticoagulate them. But remember, that's always one of the risks of being nephrotic, the incidence of thrombotic events. And then we have the other group of diseases that are called the nephritic diseases. So these patients, they present with different characteristics, and the main distinction is based on the urine sediment. So when you take a look at the urine, we all know that the urine is supposed to be bland. Like if none of us have kidney disease, hopefully, and if we were to look at our urine sediment in a microscope, we don't see any red blood cells. Maybe rarely we see a white blood cell, and we don't see any protein. So nephritic patients, they tend to have RBCs. So on your boards, you're gonna be asked about pictures of urine sediment. The most common one that you get at your level of training is the muddy brown cast, which we all know that is ATN, and I'm sure you've seen pictures in a medicine textbook. It's very easy to distinguish that type of urine sediment, but the muddy brown sediment can also coexist with other types of sediments. So the nephritic patient, by definition, they have red blood cell casts. But the red blood cell cast, number one, you need to be trained to be able to detect those casts. Most labs, what happens is that they have an automated UA, and when the automated UA picks some abnormalities, either because they have protein or they have cells, then a technician is required to do a microscopic analysis of the urine sediment. But they're technicians. They may miss important things like red blood cell cast. So as a general exercise, every time I'm confronted with a question whether or not this patient may be having an RPGN, you guys know what an RPGN is? rapidly progressive glomerulonephritis. So those are the probably one of the few things in nephrology that you do not want to miss, because the next time that you see that patient in 3 or 4 months, that patient may be on dialysis. So I'm going to talk briefly about RPGN and the different types of rapidly progressive glomerulonephritis syndrome. So as a general rule, when I'm confronted with that question, I personally go and I take a urine sample, I spin it down for about 10 minutes, and I just put the urine sediment in a slide, and I look at it in the microscope. There's no rocket science, it's pretty simple, you don't need to do any staining. You can see, most of the time you see some elements of muddy brown, but you can also see interesting things like red blood cell cast. The pathognomonic cell that's associated with glomerular hematuria is called acanthocytes. I don't know if you heard about acanthocytes, but some textbooks call them the Mickey Mouse cell. It's basically red blood cells that have been deformed by the passage through the glomeruli, and they literally look like a Mickey Mouse cell. And so if you see an acanthocyte in a urine sediment, that's never normal. That's actually that's pathognomonic of glomerular hematuria. But you can also see a lot of hematuria, but hematuria doesn't necessarily come from the glomeruli. When we're dealing with hematuria, we always have to remember that the hematuria may be coming from anywhere in the kidney, anywhere in the pelvis, in the renal pelvis, anywhere from the uterus, anywhere from the bladder, anywhere from the prostate. So a lot of different things can explain hematuria, but if you do see acanthocytes or if you see red blood cell casts in the urine sediment, that's very abnormal and that needs to be further evaluated. We're going to talk later about the indications from doing a kidney biopsy. And I don't know if you guys have ever seen a kidney biopsy or if you know a little bit about that. So we'll talk about it, and you're going to be able to tell whether or not a patient needs a kidney biopsy when we're done with this talk. Okay, so again, in the urine you can see protein. The more protein, the more likely that you're dealing with a nephrotic type of syndrome. And which one is the most common cause of nephrotic syndrome, guys? You guys remember?
Minimal change.
There is actually one condition. What's the most common cause of end-stage kidney disease all over the world? Diabetes. Yeah, so diabetic renal disease is associated with massive amounts. Say it again? Hypertensive renal disease. Yeah, hypertensive renal disease is associated with less proteinuria. Generally speaking, if it's just pure.
I remember in Italy, both of them the highest in the world, right?
Both of them are the highest. You're absolutely right. End-stage kidney disease, yeah. So 50% roughly for diabetes, about 30% for hypertension.
In Italy, I don't remember what of them is the first, but in Italy it's
the reverse. Yeah, I don't know. I may be wrong, but diabetes is always and will always be the #1 cause of kidney failure, because it's a prevalent disease, because it's rapidly growing, and because the risk factors are completely out of control, especially in the Western society. So, but the hallmark of diabetic renal disease is these patients have a lot of proteinuria. They may ask you a question. You know, you probably heard about the Kimmel-Still-Wilson lesion in the kidney. So they may ask you, like, they may give you a picture of those nodules. But I don't think at your level, I don't think they ask you that kind of question. But it's important that you know that the diabetic urine sediment, by definition, tends to be bland. When I say bland, I mean no casts, no cells, a lot of protein. But having said that, some patients with pure diabetic renal disease can present with red blood cell casts, but that's the exception. That's not the rule, and that's actually one clear indication to do a kidney biopsy when there is when you're in diagnostic doubt whether or not this is diabetes and something else, because you can very well have both diseases complicating the picture. Having red blood cell casts is an indication for doing a renal biopsy, unless there is a contraindication. We're going to talk about it in the future. Anyway, so but other things that you can see in the urine in these glomerular diseases, you can see lipid casts, especially in severe nephrotic syndrome. You can see the Maltese cross, which is basically in the birefringence microscopy. You can actually see like these little crosses that are formed by excessive lipids. And you can see WBC's cast when you're dealing with acute interstitial nephritis. Have you guys heard about acute interstitial nephritis? Mm-hmm. So AIN is fortunately about only 4% of the causes of acute kidney injury. It's not a lot. Like I said, ATN, and then the rest. And AIN is probably one of the lower, but in your boards is a board favorite. Why? Because it's something that you need to know, because it's very time sensitive that you identify and you pull the most common offending agent. Perfect. Yeah. So the most common offending agents for AIN. Do you guys remember which medications are associated with AIN the most? Aminoglycosides is different. It causes like direct toxicity, but there are actually three medicines that you guys should know. Three medicines that are very commonly associated with NSAIDs. Very good. NSAIDs, I'm going to cover really quick. NSAIDs, because it's important that you guys know that. You're going to be prescribing NSAIDs left and right. I've done it. I still do it when I do my moonlighting in the urgent care in the ER. But before you prescribe an NSAID, just make sure you understand that you shouldn't prescribe it with someone with heart disease. You shouldn't prescribe it with someone with kidney disease. And you shouldn't prescribe it with someone with a history of bleeding peptic ulcer. NSAIDs are very toxic to the kidneys in many different ways. The most common one is the vasoconstriction associated with inhibition of the prostaglandins. That's how they work. That's how they help inflammation by inhibiting the prostaglandin production. In the kidneys, the prostaglandins are responsible for vasodilatation of the afferent arterioles. So when you're given an NSAID, effectively you're basically compromising the flow to that kidney. So I remember when I was at UCLA, they have a big sign in the door in the entrance of the CCU, very clearly saying we do not prescribe NSAIDs in this unit. And by the same token, you guys should always do that exercise. Is this person a good candidate? If somebody has hypertension, that's something I forgot to, when I left, I forgot to remind you guys that there are a lot of medications that are associated with hypertension, and I forgot to cover that on my presentation earlier this week. NSAIDs is one of them. So when you, on your boards, when you get a patient coming in with systolic blood pressure that is in the range of hypertension, before you jump and you prescribe anything, they're going to ask you what is the best step. You're going to say stop the NSAIDs or stop the OCPs or refer to OB to stop the OCPs, because you don't want to be blamed for getting a baby there. But those are the things that those are the most common, and decongestants like Sudafed, Afrin. There's a lot of like street drugs that are associated with severe hypertension, including cocaine and amphetamines. And from the non over the counter, we have EPO. Have you guys heard about EPO? EPO can cause severe hypertension, and one of the contraindications for administration is if the systolic blood pressure is greater than 160, because the patients can become quite hypertensive. And calcineurin inhibitors, cyclosporin and tacrolimus, can also be associated with hypertension. So I forgot to mention, but I just wanted to make sure that we covered that. And some of the cancer agents, we have a very specific group of medicines called the VEGFs, the vascular growth endothelial factors, and the VEGFs are associated with severe hypertension sometimes, and they have a big role in the treatment of solid malignancies like ovarian, gastric, and more like they're using it for other indications like retinopathies. They use the VEGFs for management of that. And they're also using them for some patients with bleeding diatheses, like telangiectasia syndrome and things like that. But that's a separate topic. Okay, so going back to the NSAIDs. So NSAIDs can cause damage that way, like by cutting down the flow to your kidneys. But they can also cause damage by causing a primary GN. One of them is minimal change disease. In fact, it's actually when you have minimal change disease, you always have to inquire about NSAIDs, always, especially if it's a child. NSAIDs are notorious for causing minimal change disease, but they can also cause secondary membranous glomerulonephritis, and then NSAIDs can also cause acute interstitial nephritis, which is how we ended up covering this part. When you use a lot of NSAIDs, you can actually cause very ominous complication, which is called necrosis. yeah, I'm blanking out, but basically it's necrosis of the pelvis of the kidneys, and these patients can present with severe acute kidney injury. So the bottom line is for you guys, when you go out and you're in the real world, before you prescribe it, think about it. If the patient has hypertension, it's probably not a good choice for them. If they have kidney disease, big no-no. And if they have severe heart disease, you shouldn't do it. Okay, very good. So going back to the urine sediment, so things that we look for if you see that the urine sediment is bland and the patient has acute kidney injury, then you think about ATN. If you see some cells, a few RBCs and a little bit of protein, when I say about 1 gram of protein, then you start thinking, does this patient has a nephritic syndrome? And that's when you start thinking, maybe this person needs a biopsy. And the biopsy, you can probably understand that in nephrology, that's the gold standard for us to be able to have a definitive diagnosis, because a lot of these diseases can present similarly. They can present with acute kidney injury, a little bit of protein, some cells, but it's important for us to guide therapy, to make decisions, because not every GN is treated the same way. Sometimes we need to do plasmapheresis, or sometimes we need to do IV cyclophosphamide, or sometimes we just treat them with anti-proliferative agents like Imuran or Celsip. So we need to be able to make that distinction. So when confronted, you always want to think about the possibility of doing a biopsy. I'm going to ask you guys, if you don't know, I'll be very glad to help. Do you know what are the contraindications for doing a kidney biopsy? You guys know any contraindications to kidney biopsies? So let's think about it. I'm going to be sticking a needle in your kidneys. Do you think the kidneys bleed or they don't bleed? You can actually die from a kidney biopsy. So you have to be very secure, very sure that this is what you want to do. So if your patient is coagulopathic for any reason, that's a contraindication. If the patient is on Coumadin, we need to transition them to Lovenox and explain to them that their bleeding risk is higher than the general population. If your patient has cirrhosis, you do not want to do a biopsy on a cirrhotic patient. If your patients have severe or uncontrolled hypertension, you don't want to do it, because the risk of bleeding is much higher in those suffering from uncontrolled hypertension. So generally speaking, we want perfect hypertension control before we stick a needle in the kidneys to minimize the risk for complications. But as a nephrologist, I always think about not only the necessity of establishing a diagnosis, but also what am I going to do with that information. And if I have a patient with multiple comorbidities that you know for a fact that this person is not going to be a candidate to get immunosuppressive medications, why bother? Why? Because you're putting your patient with the risk of a procedure for no benefit. Establishing the diagnosis is not necessary. Not even if you end up developing kidney failure. Is not a contraindication. That doesn't preclude you from having a transplant down the road. So when I'm confronted with a question about doing a biopsy, I think about the individually. I think about the comorbidities. I think about what am I going to do with this information, and I disclose that to the patients. If we end up doing a biopsy, would you be willing to consider treatment for this type of disease that you may or may not have? If they say absolutely no, I'm not willing to take those poisons, I've had that instance in the past, and the patients decide not to, and then you just try to do medical management without going further. But yeah, so those are primarily the contraindications. If they're taking antiplatelet agents, any type of anticoagulation, and uncontrolled hypertension, and whether or not you're going to be doing something with that information. If you have a Hep C IV drug user that has a chronic osteomyelitis and is non-compliant, not showing up for the appointments, you know that you're not going to do a biopsy in those patients. So establishing the diagnosis is one thing, and doing something with that information is something else. Okay, so basically we go back to thinking about the urine sediment. So that's important to make a decision whether or not you need a biopsy. But what are other features of the patient with nephritic syndrome besides the active urine sediment clinically? What other things? What are the clues that can point towards a nephritic syndrome?
Signs of like an inflammatory process.
Yeah, they become very hypertensive. Remember we talked about like the other day, like those patients with true nephritic syndrome, they can become quite hypertensive. They can have systemic inflammatory diseases like lupus, right? Or like Even rheumatoid arthritis can cause some form of kidney disease. We're going to cover that. They can have some of the small vessel vasculitis, and these patients can actually present with very vague complaints. Have you guys covered good pastures in med school? So they ask, that's a board favorite. So, or patients with ANCA-associated vasculitis. We used to call it Wegener's. We don't call it Wegener's anymore. I think they call it granulomatous and polyangiitis. And Church-Strauss, I don't think we call it Church-Strauss. We call it allergic, eosinophilic, granulomatous, polyangiitis, right? And then we have the other one, which is the MPA, the microscopic polyangiitis. Those are the ANCA-associated diseases. But we also have the anti-GBM associated diseases. When the disease is actually involving the kidneys and the lungs, we call it good pasture syndrome. When the disease is only involving the kidneys, we call it anti-GBM glomerulonephritis. And why is it important that you recognize that entity? Because the management is very different. If you're dealing with somebody with good pastures, you better move fast, because those patients need plasmapheresis. That's one of the things that is so important to do a biopsy. And even when you suspect it, you don't even wait for the biopsy results, because remember, once we get a biopsy, we send the samples for light microscopy, we send it for immunofluorescence, and we send it for electron microscopy. It takes no less than 2 weeks for the IF and the EM to come back, and that's where the money is if you're confronted with a question about good pastures or anti-GBM disease. So the diagnostic test is to order an anti-GBM antibody. That takes about 2 to 3 days in most hospitals. If you have it, if your test is positive in the right clinical setting, you don't wait. You don't wait no further. You call the company to start doing plasma exchange on your patient. Otherwise, they can develop severe irreversible renal failure, or they can develop severe pulmonary complications, hemoptysis, and there's a condition called diffuse alveolar hemorrhage that it carries significant morbidity and mortality. So that's why these diseases you have to move very fast. There's another type of kidney disease that is they love to ask that question on the boards, which is called TTP. You guys remember the pentat constellation of symptoms, how these patients present? For TTP, thrombotic thrombocytopenic purpura. Yeah, what are they?
You have like polygonal purpura. You've got purple striae, I believe.
So it's altered mental status, because these patients they're very confused. They're thrombocytopenic. They have anemia, hemolytic anemia. They hemolyze, so you look for schistocytes. If they give you a question, they may show you a picture of a peripheral smear. I want you guys to be familiar with the appearance of the schistocytes, because they have several questions on the boards with the schistocytes. That's basically that's the sign of MAHA, microscopic hemolytic anemia. I'm trying to think what MAHA means. And you can Google it for me, MAHA. Yeah, what MAHA stands for. That's basically when you have schistocytes, and that's a pathognomonic sign of hemolysis. And these patients present with renal failure, and anemia, renal failure, altered mental status, thrombocytopenia, and fever.
You want to know what MAHA?
MAHA, yeah.
Microangiopathic hemolytic.
Thank you. Microangiopathic hemolytic anemia. So that's actually when you see that, you have to call a rheumatologist, because that means that there's a underlying autoimmune disorder. All right, so those are like syndromes that they ask you on your boards. The way you treat that one is also with plasmapheresis. So I'm sharing this with you because I got it wrong the first time I took my boards. So when you're confronted with the possibility of TTP, or where you're confronted with the possibility of anti-GBM or good pasture syndrome, you have to plasma exchange this patient. So they give you, the next step is steroids. Everybody gets steroids, right? But actually the treatment that really changes or alters the course of these syndromes is plasma exchange. So make sure you guys remember that for your boards. Okay, so then we have other forms of nephritic syndrome. Do you guys remember what is the most common GN in the world? We talk about what is the most common cause of kidney failure, which is diabetes. IgA nephropathy, which is also known as Buerger's disease. Yeah, actually Buerger's disease is also some of the disease like associated with smoking, and they get like a vasculopathic injury. These patients actually have a crazy picture in the medicine textbooks. A guy with no feet, no arms, amputated, and he's just smoking through like a little cord. Have you guys seen that picture? Yeah, and that's actually a severe case, like smokers, like that's the other Buerger's disease. But IgA nephropathy is the most common cause of glomerulonephritis. It's more commonly seen in Asians and Hispanics, but it can present in any race in the world. It's less commonly seen in Scandinavian countries. But most patients with a little bit of protein, most patients with a little bit of blood in the urine, they have IgA nephropathy until proven otherwise. So does that mean that they need a biopsy? No, they don't necessarily need a biopsy. You do a biopsy in these patients, number one, if you do a 24-hour urine excretion, proteinuria excretion, and the excretion is greater than 1 gram, because we know that those patients, they have higher risk for progression. But if your patient has very stable kidney function over time, and there's little to no protein, just a little few RBCs, you don't have to do a biopsy, unless the patient is very anxious. And sometimes in practice, you're confronted with that question. Some patients, they're not going to relax unless you actually show them that this is what they have. And at the end, it doesn't really change the management, because fortunately, IgA nephropathy is a very indolent disease, and most patients have a very benign course over the years. But some patients, they actually have a very aggressive course. And when we talk about RPGN, one of the differential diagnoses for RPGN is crescentic IgA nephropathy. So when you guys hear the word crescents, that's no good. When you hear that or you read that somewhere, that means that there's a lot of active inflammation replacing the glomeruli, forming those fibrin deposits that we call crescents, because they look like a moon in the inside of the glomeruli. When you hear that, that means like something really, really bad is going on with the kidney. Something is very inflamed. So always remember that crescents, no good. So IgA nephropathy, to summarize, it can be, most of the time, is a very indolent, very benign course. But sometimes patients have some features for progression, especially if they have near normal or abnormal renal function, or they have a lot of proteinuria. Those patients, they need to be treated. But there is a very small percentage of patients that they can have a very aggressive and very progressive course. Right now, I have a 19-year-old woman with severe crescentic IgA nephropathy. I've given her twice 2 rounds of Cytoxan. Each round is 6 months. It's a monthly injection for 6 months. I let her rest for about 3-4 months. The proteinuria came back, the inflammation came back. I told her, I'm not gonna treat you again unless I have another biopsy. I did another biopsy on her. The inflammation is still there. Very, very active inflammation. And there was no other choice than treating her again with Cytoxan.
19 years old?
19 years old. And most likely she's gonna end up losing this fight, because there's so much Cytoxan I can give her. You guys know what the side effects of Cytoxan are? Cyclophosphamide? Yeah. Infertility. So you either treat it and you disclose that to the patients. She may develop infertility, and I told her. And we use some progesterone, Mesna. Not Mesna, Depo-Provera, to supposedly put the ovaries to sleep, to protect them against the infertility. But Cytoxan is a tough medication, and there's so much Cytoxan that you can get throughout your life. The maximum cumulative dose is about 35 grams in your lifetime. And every time I was treating her, I was giving her 0.5 grams per body surface area. So this is the second cycle, and she still has active inflammation. So just to show you guys how IgA nephropathy can be very benign, can be very slowly progressive, or it can be very aggressive. And this woman belongs to that category. So that's basically the most common nephritic. So what I want you guys to do is to have a volunteer to start reading the clinical case, and we'll go over the things that are important. If you can start reading the heading, you can help me with that.
DMD nephrology case 2 nephrotic syndrome.
Mm-hmm.
40-year-old man has come to your office with a complaint of swelling of his body over the past several months. He states that approximately 3 months prior to admission, he had fallen off his bicycle and bruised his right leg. He noticed swelling in the leg at the time, and soon thereafter noticed both of his legs had become swollen. Over the past several months, he noticed the swelling had increased over his entire body. He reports a 20-pound weight gain over that period of time. Discussion points. What are the probable causes of total body edema in this patient?
What do you guys think? So let's go over the differential for total body edema. When you have a patient coming in with total body edema, what do you think about?
Congestive heart failure.
Heart failure, very good. Mm-hmm. So it's cardiogenic, nephrogenic, or liver, right? Okay, those are the 3 big categories. But what else can give you, what other conditions can give you total body edema? You guys can think of.
Severe burns.
Severe burns, yeah, but we'll get a history of burns. But we probably don't see that in America, but it's quite common in developing countries. Malnourishment. You know, what is the name of that condition? Kwashiorkor, or how does? Yeah, how do they call it? Yeah. So it's not uncommon in developing countries. If you guys go overseas and you do some volunteer medical rotation somewhere, it's not uncommon to encounter that. I saw that in my medical education in Colombia. What else? What other conditions?
I'm reading it, so I'm cheating.
Yeah,
But
so
I like the hypothyroidism.
hypothyroidism, right? Severe hypothyroidism, you know, like mixed edema. What is the clinical characteristic of mixed edema? Is non-peeing, remember? Non-peeing. Have you guys seen a patient with severe hypothyroidism? Have you encountered a patient like that? It's actually pretty impressive. The thought process is very slow. The vital signs are very abnormal. These patients can be like low cardiac output. They can be like, I remember like interviewing one lady one time. She was like, I thought she was ignoring me before I knew like her TSH was 90. Like I thought she was ignoring me when I was talking to her, and she couldn't really process. She couldn't really answer back. So that's another thing to always have in mind, severe hypothyroidism. Okay, what else? So we can see unilateral edema. In which settings we see unilateral edema? DVTs. Or you can see like you can see bilateral lower extremity edema if you have like a compression lesion in the inferior vena cava. What else? Or tumors, malignancy. Yeah, but that's pretty much it. Like always think about, is this nephrogenic? Is this cardiogenic? Or is this from the liver? If you think about those 3, you're going to be fine most of the time, like 99% of the time. So whenever you admit a patient with that setting, think about those 3 things. You do an EKG, you do an echo, you do a liver ultrasound, and you're going to be fine. You're going to impress your attending. Okay, so why don't you read the second bullet point there?
Differentiate between causes of unilateral leg edema and total body swelling.
Mm-hmm.
What other historical information will be important in assessing this patient's problems?
So you told me that he actually fell, right?
Mm-hmm.
So what do we normally do when we have a trauma and we have pain?
We want to check out the brain and make sure there's not some kind of a hemorrhage.
That's pretty standard for ER doctors. They rule out any type of like acute brain injury. But probably what I'm trying to say is, what do you think this guy was doing at home? He fell, he was in pain, he was riding a bike. So what are the things you want to ask him when you get a good history from the patient?
Did you take any medication?
Right. Did you take any medications for this? And we already covered the NSAIDs and the NSAIDs associated toxicities. So we always want to, every time when you're an intern, I told you these guys on Thursday that I came in, your job is to be thorough. So thorough means that you get the prescription and the over-the-counters, always. And the illicits. You know, recreational illicits, however you want to call them. Okay, so there's a third point, right? Is there any other bullet point?
No, those were the last bullets for that one.
Okay, so let's go to the second paragraph.
He has no history of heart disease and denies PND.
Paroxysmal nocturnal dyspnea.
DOE.
Dyspnea on exertion.
Or orthopnea. He has no history of liver disease and denies a history of jaundice, dark urine, or alcohol use. He does not know of any exposure to any hepatitis and has no history of IV drug use.
Mm-hmm.
He has never told of any problems with his kidney as an adult or a child. His urinary frequency is unchanged over the past 2 months.
So those are things that you need to review when you're a student or a resident. liver disease, any signs of heart disease. On physical exam, what are the things that you look for if your patient has heart disease? What are the things? GVD,
Yeah, JV carotid.
the PMD,
PMI.
the PMI displaced.
Yeah.
What else?
Obviously the heart and the pulses.
The pulses and the presence of an S3 gallop. What else? What do you look for edema in your hospitalized patients? That's not where you look in your hospitalized patients?
Oh, they're lying down.
They're laying down. Where do you look for edema? You actually always just get used to like asking the patients to please sit up, and you put your thumb in the sacral area. That's where the edema accumulates. And even in patients with severe heart failure, chronic heart failure, believe it or not, sometimes they don't even have rails or crackles. You know, they just have the other signs of heart failure, but the pulmonary vessels, the pulmonary veins, they develop like all these new branches, and it's difficult to hear the crackles in these patients when they have severe long-standing heart failure. But in your hospitalized patient, you always get in the habit of checking it in the thighs or in the sacral area. That's where most of the edema accumulates. Okay. What else? What else does it say there?
And then it just has the points. So given this patient's history, is the likelihood of congestive heart failure or cirrhosis likely?
What do you guys think? Not really, right?
Not liver.
Normal guy, failed. He just had a bad incident, but really the review of system was all negative for both heart disease or liver disease.
And the next point is, what physical exam points should be focused on in this patient's with generalized edema? Signs of heart, we have the answers.
Signs of heart disease, right? What about signs of liver disease? What are you guys remember any signs of liver disease?
The stomach.
Right, ascites. Caput medusa, yeah. Is ascites always from the liver? You can have it from the heart, like severe right heart failure, or you can even have nephrogenic ascites for those patients with severe nephrotic syndrome. So ascites doesn't give you like, most of the times it's always the liver, common things being common, but I want you guys to think about the other possibilities. Yeah. What other things do we see in patients with liver disease? Telangiectasia, very good.
Their skin color.
The skin color, yeah.
They can't actually process things. They're a little loopy.
So you're talking about like a encephalopathy or the asterexis, the tremors. Yeah, so what about, how is the breathing of these patients with liver disease? If you were to do a blood gas on a patient with liver disease, what do you expect to see?
They're actually taking very shallow breaths.
Correct. It's like a pregnant lady. It's like they have a primary respiratory alkalosis. So when you have a blood gas and you see like primary respiratory alkalosis, you think about liver disease, and you think about pregnancy and liver disease. The reason why these patients develop primary respiratory alkalosis is because they cannot metabolize the estrogens, and so they have that's the reason why they have gynecomastia, and that's another feature of liver disease. So these patients, they have a very shallow, very superficial breathing, and if you do a blood gas, most of them they have a primary respiratory alkalosis. So you think about pregnancy, liver disease, CNS occupying lesions can give you a primary respiratory alkalosis. Gram-negative bacteremia can give you primary respiratory alkalosis. Pulmonary embolism, and then salicylate toxicity. But you have a combined, metabolic acidosis and respiratory alkalosis. We can do one of these days. We can do a blood gas talk, like if you guys are still gonna be here. So basically. So you look at the pattern of how they breathe. What else do you look for cirrhosis?
Their eyes.
What happened with the eyes?
They turn really yellow.
The icteric, yeah. Right. So what do you see in a nephrotic patient? Let's say that we're very good at identifying heart, and we're very good at identifying liver physical exam findings. What about a nephrotic? Let's say we're dealing just with a pure nephrotic syndrome. What do you expect to see in the physical exam?
Swelling.
Where? In particular, where? Eyelids. Actually, eyelid edema. If your patient tells you, I'm having eyelid edema when I wake up, that's pretty consistent with kidney disease until proven otherwise. And there is a feature in the nails. You guys can write it down, and you can Google it tonight to see how it looks. It's called Lindsay nails. It's not Lindsay Lohan, Lindsay nails. You're gonna see like, or they're also known as half and half nails. So it's like half of the nails are like white and the other half are pink. And you see that in severe nephrotic syndrome, but you also see that in severe heart failure. Lindsay nails, thank you. Half and half nails. So you see that. And so you see a lot of the, remember we talk about accelerated atherosclerosis, and this is an important management consideration for these patients. If you're treating a nephrotic patient, you do not want to ignore the lipids, because most of the mortality, most of the morbidity and mortality when you have kidney disease comes from cardiovascular complications. And these patients do have accelerated atherosclerosis and premature death as a result of not treating the lipids. So on the physical exam finding, you can find things like xanthelasmas and xanthomas. You know, have you guys seen xanthomas and xanthelasmas? Like these, have you guys seen like in the eyes, like these fatty tumors? Can you pull up pictures? Xanthomas, it can be in the skin, and xanthelasmas. So look for those things when you're examining your patients, and that's another hint, another clue to severe nephrotic syndromes. There's a picture there. Yeah. I'm sure you've seen patients. I'm sure you've seen patients with that. No, it's not pathognomonic of kidney disease, but think about nephrotic, the possibility of nephrotic syndrome. Okay, and you guys all mentioned edema. Yeah, that's actually, edema can be severe. You know, you can ask your patients, do you have any edema in your testicles or in your penis, because the edema can be severe. I mean, and most patients don't disclose that part to you. Say, I'm swelling, but you ask that specific question, you'll be surprised how many of them say yes. Okay, so but there's really like signs and symptoms of kidney disease can be very non-specific. Anemia may be a sign of kidney disease. You guys know why kidney disease patients develop anemia? EPO, yeah. So invariably, all my patients require EPO. If you have kidney disease and you don't require EPO, you may want to think about other concomitant conditions, such as underlying lung disease. You know, like hypoxemia is a very powerful driver for EPO secretion. Or you may be dealing with a patient with actually a renal cell carcinoma. And actually, I've diagnosed 2 patients with renal cell carcinomas that they didn't have anemia. I just did a renal ultrasound and they have like a renal cell carcinoma. So the take-home message is, if your patient doesn't have anemia and the patient has moderate to severe kidney disease, think about something else going on. You see the rest of them? I'm fine. Sorry, guys.
No, actually don't.
You done? Okay.
I thought you said something else.
Okay. I thought you wanted to go to the restroom. Let me know if you want to go. Okay, so basically, but physical exam wise, there's really not a lot of differences. But probably those are the few things: the nails and the eyelid edema. Okay, go ahead with the next point, please.
On physical exam, he appears grossly
Edematous.
Thank you. Edematous. And puffy. His blood pressure 145/90. Pulse.
Oh, I'm sorry to interrupt. So that's a good point. Good point of distinction. Patients with liver disease, they tend to be hypotensive. Remember? And the reason being is that they're very vasodilated. They have a lot of nitric oxide circulating. They have hypotensive. Like universally, liver disease patients, they're hypotensive. And have you guys heard about a condition called Hepatorenal Syndrome? Do you guys know what that is? You guys know, like if the liver is really in bad shape, like you have severe liver failure or fulminant liver failure, the kidneys, they develop this ischemic injury. Ultimately, is ATN. In other words, if I were to take those kidneys from that person and put them on a normal individual, the kidney will work just fine. But they develop severe ischemia because of the severe splenic vasodilatation, and is nitric oxide mediated. So that's why always remember, guys, liver patients, they tend to be hypotensive. Heart disease patients, they can be one way or the other. If they have severe heart disease with severely reduced left ventricular ejection fraction, we all know that those patients, they tend to be hypotensive. But as opposed to the nephrotic patients, their volume expanded, and they have a sodium retention because the kidney's ability to excrete sodium is impaired. So they tend to be hypertensive, And if they're nephritic, they can be severely hypertensive. So that's another hint in physical exam that you guys can look for. Okay. What else does it say there?
Blood pressure is 145/98, pulse 92, respiratory rate 16, temperature 98.6. The patient's skin shows no sign of jaundice or telangiectasia. He has no signs of palmar erythema. His face shows swollen eyelids, but sclera are not pictured. Examination of the neck shows no signs of jugular venous distension and no thyromegaly. His lung exams are clear to auscultation and percussion, with the exception of decreased breath sounds and dullness of percussion in the bases. Cardiac exam revealed a non-displaced PMI, normal S1 and S2 without murmurs, rubs, S3 or S4. Abdominal exam shows the liver to be approximately 9 centimeters in size. No splenomegaly was appreciated. There were findings of shifting dullness to percussion of the abdomen. In the periphery, the patient had a 4+ pitting edema to the level of the sacrum and throughout both legs. The patient had no signs of gynecomastia, testicular atrophy, or parotid swelling. The patient's neurological exam was normal. Discussion points. Given this examination, is it likely that the patient has congestive heart failure as the cause of his generalized edema?
Probably not, right? We all concur? Yeah. Mm-hmm.
Are there signs of cirrhosis present on this examination? You're talking about the sacral.
Yeah, we talk about the testicular atrophy. There's nothing there. You know, his skin exam, his liver was 9 centimeters, which is normal.
Okay.
Yeah, there's no splenomegaly, so probably not liver failure going on with this person.
What aspect of this examination would suggest this patient has nephrotic syndrome?
So he has pleural effusions. That's another hallmark. You know, all these edematous states can give you pleural effusions, but nephrotic patients, they tend to have severe effusions, like moderate to severe effusions. So the edema, pretty much. Like I said, there's not so many signs of kidney. Now that we're mentioning about kidney disease symptoms, have you guys ever met a uremic patient, a patient with end-stage kidney disease? Okay, so, you know, I tell the students, like always when I'm advising them career choices and everything, nobody told me this, but I found it very fascinating that in nephrology, my patients, they all feel fine. And that's problematic, because when you're trying to convince somebody that they need to do something when they don't have any symptoms, that's a problem. But when you have an advanced renal failure in a patient that's already like overdue for dialysis initiation, these patients can have several symptoms. I'm going to mention some of them just so you guys are familiar. They can actually have pruritus, what we call the uremic pruritus, so all these